worker in the organization. She was born and raised in Jamaica. Her passion for helping others ignited at an early age. Dr. McLean's expertise is in team building, leadership development, and community engagement. Is a reach for her diverse background and work in both Jamaica and the USA. Outside of work, she cherished time with family, church, and community activities, along with traveling and writing. Let us all welcome the MC, Dr. McLean.
Good evening, everyone. If you're from the Caribbean or any African country, this heat is pretty normal, right? I am Dr. Sharon McLean. It says on there McLean, but I have added Williams, as I am recently married. My lovely husband is here. And so I am thrilled to be your MC for this momentous occasion as we celebrate the launch of Motherhood of Africa Foundation. Now, this foundation is dedicated to tackling the critical health challenges of maternal health, child mortality, and proper nutrition in Ghana and the US. Your presence here tonight signifies your solidarity with our mission to empower mothers and children. Your contributions, big or small, will make a significant difference in our journey. Making this evening possible are our generous sponsors, Fidelity Bank, Loyal Home Services, Omama Healthcare, Moad, Marty's Kitchen, Erura Event Planning, and Century 21 Realty. We're so grateful to all of their contributions and donations. To make a donation tonight, simply scan the QR code. You can do so via Cash App or by PayPal. That's on your table, in your booklet. It doesn't matter how much money. One of the things I keep thinking about is that sometimes you want to give and we're thinking, I'm going to wait until I have this certain amount of money, then we're going to give, right? Let's not wait until that point. If you find yourself with $5, $10, it doesn't matter the amount, just give. And when you get the bigger money, you send that money too. Every contribution counts, and so we're counting on you tonight to be able to do that. Now, let's welcome Apostle Samuel Davidson for the invocation.
Chairman for the occasion, all protocol observed, ladies and gentlemen. It is my responsibility tonight to introduce to you the Motherhood of Africa, Ghana, and our progress report so far. So, in this presentation, I will introduce the Motherhood of Africa, Ghana, mission, vision, and core values, program objectives, program components, implementation strategy or plan, expected outcomes, collaborations and partnerships, launch of Motherhood of Africa, Ghana, project management team, next steps, and conclusion. By way of introduction, Motherhood of Africa, Ghana is a registered non-profit organization based in Takwa, Ghana. It is dedicated to support and provide financial and non-financial assistance to nursing mothers and babies facing detention at the health facilities. This initiative aims to alleviate immediate financial burdens, empower mothers to establish sustainable livelihoods, and also contribute to the achievement of sustainable development goals. Goal 3, that is good health and well-being, and goal 1, no poverty. Mission and vision. Our mission is to provide an equitable condition for vulnerable nursing mothers and babies who are detained in health facilities owing to their inability to pay medical bills, and together with our partners equip these women with resources to build a future of hope and dignity and lead healthy lives. Our vision is to serve as an epicenter for the provision of better and sustainable livelihood for women and children across Africa. Our core values: compassion and empathy. Demonstrate care, empathy, and compassion towards pregnant women, mothers, and their families to ensure dignity and hope. Respect for women's rights. Advocacy for the rights of pregnant women to save motherhood, reproductive autonomy, and comprehensive maternal health care without discrimination. Women empowerment and education. Empower women with knowledge, skills, and resources to make informed decisions about their reproductive health, pregnancy, childbirth, and postnatal care, and promoting community education and awareness on maternal health issues. Program objectives: to provide immediate financial and non-financial support to nursing mothers and babies detained at the health facilities. Empower nursing mothers to establish sustainable livelihoods through business activities. Ensure that mothers and babies receive necessary medical care without facing detention or financial barriers. Promote economic independence and self-sufficiency among vulnerable women in Ghana. Our program components: financial support to cover medical expenses for nursing mothers and babies detained at the health facilities. Non-financial supports are to offer counseling and psychosocial support to mothers experiencing distress during detention. Facilitate access to legal assistance to resolving any issues related to detention or medical bills. Livelihood support provides startup capital and entrepreneurial training to nursing mothers interested in starting their own businesses. Offer mentorship and guidance to ensure the sustainability and success of their business ventures. Community engagement. Raise awareness among the rights of nursing mothers and babies to access health care without facing detention or financial barriers. Foster community support and solidarity to address the underlying causes of maternal and child health care disparities. Our implementation plan. The implementation plan strategy of our initiatives involves the multifaceted approach that addresses various aspects of maternal and child health, economic empowerment, and community development. This includes: A. Service delivery. Provide comprehensive maternal and child health care services, including maternal and postnatal care, skilled with attendance, family planning, and child immunization. Offer financial and non-financial support to nursing mothers, including coverage of medical expenses, transportation assistance, and startup capital for income-generating activities. Facilitate access to psychosocial support, counseling, and education on maternal health, nutrition, and child care. B. Livelihood support and economic empowerment. Offer training and capacity building programs to enhance the entrepreneurial skills and financial literacy of the nursing mothers. Provide startup capital, equipment, and resources for income-generating activities such as small businesses, agricultural, and handicrafts. Mentorship and ongoing support to ensure the sustainability and success of businesses established by nursing mothers. C. Mentoring, monitoring, and evaluation. Implement robust monitoring and evaluation mechanisms to track progress towards program objectives and outcomes. Collect quantitative and qualitative data on key performance indicators related to healthcare utilization, health outcomes, economic empowerment, and community participation. regular review program activities, identify challenges and lessons learned, and make necessary adjustments to improve program effectiveness. D, community mobilization and awareness. Conduct community mobilization and sensitization campaigns to raise awareness about maternal and child health issues, available support services, and rights. Organize community workshops, focused group discussions, and educational sessions to promote healthy behaviors, maternal nutrition, and breastfeeding practices. Engage local leaders, women's groups, and community volunteers as advocates for maternal and child health empowerment. E, advocacy and policy influence. Advocate for policy changes and increase government investment in maternal and child health care, including access to essential services and financial protection mechanisms. Participate in advocacy campaigns and coalition building efforts to address systematic barriers and maternal and child health empowerment. Expected results: improved maternal and neonatal health, reduced maternal and neonatal mortality rates, enhanced economic empowerment and financial stability, more gender equality for empowerment for poor, vulnerable women, community resilience and social cohesion, sustainable development, and poverty alleviation. Partnership and collaborations. Forge partnerships with local healthcare facilities, government agencies, community-based organizations, and other stakeholders to leverage resources and expertise. Collaborate with corporate sponsors, philanthropic foundations, and international NGOs to secure funding and technical support for program implementation. And the launch of Motherhood of Africa. Motherhood of Africa team collaborated with the Tapa Municipal Health Directorate, religious, traditional, and other opinion leaders of Tapa to organize a formal unveiling which took place on the 23rd March 2024 at the precincts of the Tapa Government Hospital. In attendance were the representatives of the Tapa Municipal Health Directorate, Apostle Samuel Davidson, official head of the Church of Pentecost, that is my good self, Mrs. Owusi, Chief Executive Officer, founder of Motherhood of Africa, Mr. Kingsley Edmond Beidu, Country Director of Motherhood of Africa, Ghana, Honorary Dr. Giti Anti, media personnel, some members of the community. Mrs. Owusi recounted her personal experience at the Tapa Hospital years ago when she had checked in to deliver. She saw how deplorable the conditions are, and this experience motivated her to work hard to help poor, vulnerable nursing mothers during the journey of motherhood. 5 nursing mothers detained at the Tapa Government Hospital for non-payment of medical bills became the first recipients of the initiative. All their bills were paid for. Each beneficiary also received 1,000 Ghana cedis as livelihood support, capital, and some diapers. Can we give a hand for that? Now the picture depicted is the community members listening attentively to the CEO, founder of Motherhood of Africa Ghana, giving her keynote address as depicted in the picture. The next picture also depicts Dr. Giti Anti addressing the gathering, and then also the CEO and country director of Motherhood of Africa in a group picture with the beneficiaries. Now, project management team. Motherhood of Africa's management structure includes a board of directors whose membership consists of eminent Ghanaians with background spanning finance, medicine, law, business, management, human resource management, and psychology. The board would provide guidance on the management and execution of the organization's activities and programs. The board would also assist the country director in strategic planning and decision making. Currently, 7 persons have confirmed their membership of the board, comprising 6 gentlemen and a lady. The management team is made up of the country director, project or program manager, finance and administration manager, media and public relations managers, and field officers. Our next steps: inauguration of the board of directors, review of projects of business proposal and appropriation of funds to activities and programs, review work plans, submission of finalized proposal to corporate or private organizations for funding. Conclusion: the program is gradually taking shape and will impact greatly and positively on neonatal and maternal health and reduce maternal mortality rate in Ghana. Besides, the livelihood of the nursing mothers will be improved and sustained, leading to better nutrition for the newborn babies. Thank you very much for joining.
Thank you so much, Apostle, for providing the background of why we're here today. And if you haven't already, look through your booklet or on your table and go ahead and scan that QR code and continue to invest and support this great mission that Motherhood of Africa is undertaking. I would like to acknowledge some dignitaries that we have here today. Please, I apologize from now that my Jamaican accent might twist some of these names, so I'll do my best to call them. So from the Worcester Department of Public Health, we have Ian Wong, we have Emile Sonda, Michelle Horn, and we also have the Ghana Consulate, Honorable Ken. Oh boy, this one's gonna give me a...
It's okay.
Are you here? I'm just going to keep it at Honorable Ken. From the office of Senator Robin Kennedy, we have Kiana James, the District Director. From the Worcester Regional Chamber of Commerce, we have the President, Tim Murray. We also have Linda Salem and Mike Kane. And then from the clergy, we have Pastor Forson, District Pastor for the Worcester Area Church of Pentecost, Reverend Ofori from the Methodist Church of Ghana, Reverend Father Enoch, I'm not sure I want to try this one, from the Roman Catholic Church, and then we have Bishop Vasco Abroni. So if we could just give a round of applause for all of these. And now I would like to invite Fidelity Bank, our main sponsor, to say a few words.
Good afternoon. Thank you, Lucy. It is a real honor to sponsor Motherhood of Africa Foundation this afternoon. My name is Eric Tolkien. I've been with Fidelity Bank as a Senior Vice President for 21 years, working in commercial banking, and have the pleasure of helping our commercial clients with their banking needs and solutions. For those of you who don't know Fidelity Bank, we are a full-service community bank that has been servicing Central Massachusetts for 134 years. We operate 13 banking centers in Central Mass. We work with families, businesses, and nonprofits and municipalities to get them where they want to be. We have all the products and services and the technology you will expect from any bank, large or small. But what sets us apart are three important words: caring, clarity, and confidence. Really, those words are why Fidelity Bank exists. Throughout our life design approach to banking, which is designed to bring clarity and confidence to all our clients regarding their financial decisions, we do this with a straightforward but powerful four-step care process that everyone in our bank uses when working with clients. And this has never been more important than now. Our client tells us that the value of clarity and confidence has never been more important. If the value of care, clarity, and confidence appeals to you, please reach out to me or any of our talented bankers. Thank you for letting me introduce you to Fidelity Bank, and I look forward to a successful event. Good afternoon.
I am truly honored to introduce Nana, and she will come up and give a few remarks. She is an all-rounder, and many of you know she is very invested in helping others. And so she has done so through her business, Omama Services and Home Health Care, and through her now found support through the Motherhood of Africa Foundation. Nana was born in Simpa Pepsa in Western region of Ghana to Honorable Samuel Joe Gansa, a former member of Parliament of the Republic of Ghana, West Africa, and Madame Matilda Dapa. Her early school days started from Ideal Prep to Our Lady of the Apostles High School, popularly known as Ola in Ghana. She also attended Northern Virginia Community College for her Associate of Science Business Administration and the University of Valley Forge of Pennsylvania for her Bachelor's in Business Administration and Master's in Business Administration. Just remarkable, right? She's like pro-education, I'm going for it, I'm gonna do it. And so she's a remarkable woman, and she's a testament of her dedication, diligence, hard work, and just her perseverance in ensuring that she perceived excellence and brilliance. She balances the demands of executive role while furthering her education. This is not an easy task, but her success in doing so is truly inspiring. As a proud, responsible mother of 3 beautiful girls, she is married to Mr. Charles Antwi, who happens to be the Asante Chief of Massachusetts. Nana is a proud member of the Worcester Chamber of Commerce and is a member of the delegation that recently went to the White House. Now this is huge, and I was here to witness it as well, that she was the recipient of the BIPOC-owned Business Year Award by the Worcester Regional Chamber of Commerce. Her exploits have found her stories being published on Ghana Web and the Business and Financial Times in Ghana, and recently by the Worcester Guardian. Please help me welcome Nana.
Good evening, ladies and gentlemen. I'm short of words, but I'll try. I want to especially acknowledge one or two people. First, I want to acknowledge my husband, Mr. Charles, who is here for. He's here. Mama Achalfo of Asanteman, and Mr. Ola yeah, so he is a very good friend of mine. Adakola, he's in WPI from Nigeria, and he's a very good friend of mine. I invited him, and he personally showed up. So thank you so much. And also to Mrs. Lisa of GIA Home Health. Thank you so much for coming. And also to the cyber group, I know that the cyber guys are here. Thank you so much for coming. Okay, Mr. Chairman, special guest, special invited guest, the media, ladies and gentlemen, all other protocols duly observed. Together with my husband, Charles, my team here, and the team in Ghana, West Africa, I say a very good evening and thank you 1,000-fold for honoring this invitation. Indeed, the presence of the chairman of the Motherhood of Africa Foundation, thus the West Africa branch all the way from Ghana, is a testimony to how we are taking this foundation to a different level. Similarly, the presence of all the important people here is also a clarion call for us to take maternal health care amongst the African women immigrant community to a greater pedestal. Mr. Chairman, ladies and gentlemen, it will be very disingenuous on my part if I continue my speech without recognizing the effort of some organizations who have equally championed for the quality maternal health care amongst the African immigrant women population in the United States. At this juncture, permit me to salute the following organizations: National Birth Equity Collaboration, Black Moms Matter Alliance, the Shades of the Blue Project, the Black Maternal Health Caucus, Mama Glow, and the Doulas. I know Michelle is here. Yes. All the others that cannot be mentioned for want of time. Mr. Chairman, maternal health care challenges among the African community in the United States is frequently encountered by women migrating from low or middle income countries in Africa. These immigrant women encounter various obstacles including economic, social, linguistic, and cultural adjustment when seeking across a suitable healthcare services. As a result of this impediment, African immigrant women report poor maternal health care utilization. They are therefore less likely to receive preventive health screening. Many people die from problems related to pregnancy or delivery complications. Every death is a tragedy, especially when all we know that more than 80% of pregnancy-related death could be prevented. Among the Black immigrant women population, too many people experience severe unexpected health problems related to pregnancy that may have long-term health consequences. In my candid opinion, one cannot deny the fact that maternal health experiences of African immigrant women, other utilization of healthcare services, and the effect of maternal health have received limited attention in research. Mr. Chairman, ladies and gentlemen, as a living testimony or a victim, I am fully aware that environmental and cultural factors have a great impact on maternal health practices of African immigrant women. Public health intervention should be implemented to advance African immigrant women's healthcare utilization practices throughout required health education, which will translate to positive maternal health experience. African immigrant women have elevated rates of postpartum depression, maternal death, preterm birth, and other advanced birth outcomes. The heightened risk may be associated with untreated conditions present before they immigrated to the United States. Mr. Chairman, African immigrant women also have higher rates of poor pregnancy outcomes due to lower rate of obstetrics intervention. Therefore, in the minds of Motherhood of Africa Foundation, the unique care needs of population of immigrant women needs to be explored to design interventions to improve their health outcomes. To us, in the foundation, African women maternal health is a state of emergency. Protecting the health of mothers and babies is critical measures of the country's development. Therefore, we should all come together and join the foundation to succeed and accomplish a mission and vision. Together we shall build. God bless the United States of America. God bless the state of Massachusetts. God bless Africa. God bless you all. I thank you for your attention.
Wow, can we give her another round of applause? When we hear those statistics and just those findings, the reality of it is that it can affect anyone that we know. And I believe in community. And even if you're not related to that person by blood, you're related to that person in some regards. And so that is why it's so important, the work that this, amazing organization and foundation is doing, and that we should ensure that we are supporting. So again, grab your booklets or the QR code on the table, and just remember to give something before you leave this evening. So we have remarks from, we have a lot of important people here tonight, and it just goes to show how much support that they have for Nana and this mission. And so we're going to invite Dr. Matilde Castillo, the Worcester Commissioner of Health and Human Services, to give some remarks, followed by Jermo Kamara, the President of MOAD, and then we'll have Kiana James, the District Director from the Office of Senator Robin Kennedy. So, Dr. Castillo.
Thank you. I don't know if it's good afternoon or good evening, but thank you so much for inviting me. It is truly an honor and a pleasure to be here with all of you today. I am hoping that this will be the beginning of a long relationship and that we get to know each other and work to enhance your objectives and desires. My name is Dr. Maddie Castillo, and I'm the Commissioner of Health and Human Services for the City of Worcester. I am an immigrant to this country from Cuba and arrived as a young child. I remember all the trials and tribulations my parents had as a Latino family in this country. It is my goal in the city to help families and make it easier to navigate our complex system and assist whenever I can. I am always a phone call, a text, or an email away if you should ever need me for anything. It is also my pleasure to be here and celebrate the launch of Motherhood of Africa Foundation, so thank you for inviting me. You're pretty amazing. And address the equity healthcare and how we as a community can work to improve them. In public health, we function in data. My goal is to give you some data, but not to scare you, but to think about how we change these inequities that exist. How do we improve healthcare and outcomes, and how are you a part of that and what you need to know to take care of yourself? Maternal mortality in the United States is exponentially higher than in any other industrialized nation. As of 2020, the United States had a rate of 23.8 deaths per 100,000 live births. But for comparison, in France, they have a rate of 8.7 per 100,000 live births. We know that it does not end here, that when we look at who is dying, it is disproportionately Black women. The state of Massachusetts is known to be one of the better places for healthcare and has performed well on indicators for reproductive care and women's health. However, Massachusetts scored very low on severe maternal morbidity, which is medical problems during pregnancy caused by treatment or lack of treatment, ranking 45th out of the 50 states of the United States. The state's Department of Public Health saw that from 2011 to 2020, severe maternal morbidity doubled, going from 52.3 to 100.4 per 10,000 deliveries. We know that this does not affect all birthing people equally. Communities of color see the highest rates of maternal morbidity, with Black, non-Hispanic women having a rate of 146 per 10,000, and Hispanic women, 81 per 10,000, compared to the white community, which is 63 per 10,000. Black women also had the highest prevalence of hypertension, preeclampsia, eclampsia during pregnancy. They also had the highest numbers of postpartum hospitalization. It was found that even the wealthiest Black mothers are likely to die in childbirth than the poorest white mothers. These are all due to a combination of factors stemming from barriers to accessing quality health care, including fewer prenatal visits and lower quality of care during pregnancy and childbirth. We also know that implicit bias and systemic racism in the healthcare system can lead to poor treatment and outcomes. The social determinants of health, which are the conditions in which people are born, where people grow, live, work, and age, that influence health, along with chronic conditions such as hypertension, diabetes, obesity, can increase the risk of adverse outcomes. Most importantly, chronic stress from experiences of racism and discrimination can negatively affect physical health. There's a term that we use to describe what happens to your body with this increased amount of stress that people face, and we call it weathering. And it is the physiological wear and tear of the body which causes an accelerating aging process that contributes to early onset of chronic disease. We also see that communities of color have a mistrust in the system, and therefore there's a delay in seeking health care. They also face financial constraints or lack of awareness of the importance of early, regular prenatal care. So making sure that we address these inequities requires systemic changes in healthcare delivery. We need increased cultural competence and implicit bias training for all healthcare providers, and we need more providers that look like us. And I say that just because I'm Latino, we need more of them too. We need to enhance support services with doulas and midwives who can offer continuous care during pregnancy and during childhood. We need to go out into the community and implement community-based education that focus on your specific needs. We need policy changes that address these disparities and continue to look at data. Data is key to everything we do, and most importantly, making sure that the numbers are decreasing. None of this can be done without the collaboration of the entire community. I want all of you here to help one another, to get informed about seeking early care and making your appointments, making all appointments. And if you cannot for some reason, reschedule right away and make your appointments. I tell you not to miss any appointments. People tend to develop a feeling when people miss appointments. And we don't want anybody in healthcare to be developing any feelings in that sense. Be proactive in getting information and explanations to whatever you don't understand. Don't leave the doctor's office until every question that you have gets answered. Try always to go to someone. I always tell people that I never go to the doctor's office in spite of being a doctor or be hospitalized without having somebody next to me. I want somebody to also listen to what they said, never go alone. And people tend to treat you differently when there's somebody else in the room. So take care of your medical issues, whether it's hypertension or whether it's diabetes or obesity. A good healthy diet and exercise is incredibly important. Read and continue to read more about what to expect during childbirth and pregnancy. And be aware of warning signs, such as you can have headaches, you can have vision changes, you can have abdominal pain, shortness of breath. There's a ton of warning signs that means that you need to get care right away. Get a group support. Have people take care of your kids. Have them make meals for you. Do whatever it takes for you to relax during this process. You have your work to do, and so does our healthcare system, to improve the inequities that exist. We in the city are committed to this work, and we know also that the state has made Black maternal morbidity and mortality a priority in their work. We need you to inform us and work with us to be able to make progress in what is a beautiful and happy event in our lives. Thank you so much, and I look forward to hearing from you and working together with you. Thank you so much.
Thank you so much, Dr. Castillo. Jermo? And then we'll have Kiana come up after Jermo.
So I want to say hi to everyone that's here today, and thank you to Nana for such a wonderful organization. My name is Gemma Kamara, and I also want to say thank you to Dr. Castillo for that wonderful explanation and data about the importance of maternal and child care. My name is Gemma Kamara, and for those of you who don't know me, I have been serving as the president of the Massachusetts Organization of African Descendants. I'm formerly also an elected official serving the school committee here in the city of Worcester. And you may be asking, like, why is this an important topic for me and for our community? Over the past years, having been raised in Worcester, over the past years, one of the main things that I think we've seen, even working with other African-based leaders in the community, I know I want to sign, because Jane is here from UHA, and Honorable Ken is here, and as well as some of the other members, I know Lisa is here, who's been doing amazing work in the community, is the theme of us coming together and working together, and even though we have different ethnic base, or we're from different parts of Africa, because this is an organization that has done amazing work in Ghana, and with the hope of doing that same work here in Worcester and the USA. And that theme of community, right, coming together has been always very essential and important. So as a female, as a young person, one of the things that we did was to come together from many different African backgrounds here, people who live in Worcester, as well as in the Commonwealth of Massachusetts, because we see the need to work together, to have one voice. And even though we may all have our different businesses in the community, that perhaps we can all be of resource to each other, such that when there's something, an organization starting on like this, right, we are all coming together and supporting. So that's what MOAB, the Massachusetts Organization, is, and we have a coalition of members of over 200 African-based from different African countries. We've done amazing work, and Nana Omama Healthcare has always been our key supporter in that initiative, from sharing financially and to even imparting her knowledge at our African Business Expo. And it is only fitting for us to stand here, for me to stand here and represent and pay that back, but then also continue. I also want to signal, because the last time I was in Ghana was 2014, and I had a public health internship there, and when I was in college, and it was one of the most amazing experience of my life. And one of the key things that we did was to work in Pokwasi. We worked in kind of outside of Ghana, Pokwasi, Ghana, and we worked in the community, and we brought support, educational support. Some of it also included sanitation, and another piece of it was included working with a clinic that weigh babies and offer nutritional care. And since 2014, I have not been back in Ghana, but I've held a strong relationship with the Ghanaian community, a lot of their top leaders here, Nana, but then also Mr. Ken and other, some of the pastors, reverends in the community, and even Bishop and Reverend, what am I forgetting your name? Enoch. Of the diocese, and it's just incredible to have all of these connections, and in that also to impart why this event is so important, and as we gather to learn about, as we have learned about this organization, but then for us to also be of support in terms of financial support, to give back, so that this work of Omama Healthcare, Motherhood of Africa, not only continues in Ghana, in a place that women, mothers, so dearly need that services, because they don't have the healthcare system that we do have here, the insurance and different social services that we are that we are blessed with here for this organization to support women and children in Ghana, and to also do the same thing here locally in Massachusetts, because as Dr. Castillo mentioned, Black women and African women, I know that another speaker is going to talk about some of the work that has been done in Worcester around women's health, but then maternal mortality or maternal supports here in the city of Worcester. And I do know that these are all important aspects as we all continue to address key disparities in health. And so I don't want to take too long. I just want to say thank you, Nana, for this occasion. And as a president of the Coalition of African Community, I want to say that we are supporting you, we're behind you. In fact, one of our subcommittees deals with public health in the community, and I know we work with different organizations like mental health services. Jane does that services, and even now with you, to be able to get into our community, because it's one thing for all of us here to have dinners and talk and raise money, but the main work is when you can get to the community, and that's something that I have been very much engaged in grassroots organizing. So in any ways that I can be a support, the organization can be a support, it's very instrumental. I'm there. So thank you all for your time.
a trip to Ghana, right? Although we still want you to go to Ghana. But we just experienced cultural vibration. Please give them another round of applause. So again, our purpose here is to support Motherhood of Africa Foundation. And so as a reminder, you can scan the QR code, and we also have a table at the back that you can go and you can make your donations as well. So please, before you leave tonight, ensure that you are donating to Motherhood of Africa. Now, I have the privilege to introduce our keynote speaker, Dr. Dale McGee, former chair of Worcester Infant Mortality Task Force. Dr. Dale McGee reviewed every infant death and stillbirth in Worcester from 1999 to 2015 when he retired. He analyzed the data that found a high rate of infant mortality in Worcester's West African population. He practiced obstetrics and gynecology for his whole career in this area and was an associate professor of clinical obstetrics and gynecology at the UMass Chan Medical School. Mid-career, he did a master's degree in health policy, quality measurement, and epidemiology at Dartmouth Institute. In addition to his work on Worcester's Infant Mortality Reduction Task Force, he has served on the Worcester County Child Fatality Task Force, the State Maternal Mortality Review Committee, and the State Birth Defects Monitoring Group. He has helped to develop quality measures for obstetrics for the National Quality Foundation. He has served as the president of the Massachusetts Medical Society, medical director of Central Massachusetts Independent Physicians, and commissioner of public health for Worcester. He was elected for 4 terms on the Shrewsbury School Committee from 2010 to 2022. Please help me welcome Dr. Dale McGee.
Thank you so much for that nice introduction, and I'm honored to be here to speak with you today. If you look at your schedule for this event, you'll know that I should be saying, and now I'm finished. And it's down for 20 minutes. My talk is 40 minutes. I'll warn you about that in advance. But I think that what I've got to say to you is so important that I know that running into the dinner a little bit is worth the risk to me, because there are some perspectives here that I want to give to you. This issue regarding maternal mortality and infant mortality is emotional for everyone. It captures the attention of the entire community. When you hear that black infant mortality and maternal mortality is even higher, when you hear that a big part of that is racism, that certainly doesn't leave you feeling very good. It doesn't leave you with much hope. And many of you immigrated to this country for a better life. And so I think that we owe you more than that, and I owe you more of an explanation as to what we are talking about, what these measures show. Try to put them in perspective for you so that you can understand the meaning of these changes, the meaning of these measurements, what you can do, what your physician can do or your healthcare providers can do, and also what they can't do, so that you can understand better and go away with a better understanding rather than simply hearing that it's sky high, it's getting worse, and it's especially worse for you. Now, before I get started, I think that we have the expectation of saying that if people are not healthy, that really they need to go to the doctor immediately, and that the relationship between the healthcare profession and people's health is one-to-one. But really, there's a lot more involved with health than just healthcare. And this graphic here, which gets used a lot, says that healthcare is worth 10% of your overall health. But I think there are elements to this that you understand. That you understand that if you get an education, if you get a good job, if you live in a good house and you have plenty of food, that you won't not only live a better life, but you live a longer life and a healthier life. And that's what we're talking about here. And the other piece of this has to do with the issue of stress that gets brought up, particularly in this context with regard to racism. And there is an issue here in the sense that stress and racism aren't things that we can draw a blood test on. It's not things that we can administer a treatment for, but it certainly is real. It has its effect. And it is known throughout society that if you are in a stressful situation, regardless of the cause, your health is going to deteriorate as a result of it. So those sorts of things are well established, but what can you do otherwise, and what is it that we are measuring? When we talk about infant mortality, I think the important thing to understand is this is a measure that has been used for hundreds of years around the world. And the reason for this isn't just to look at the health of the infant that has been born, the child that lives until its first birthday, but rather how well a community supports those that are completely dependent, how well a community supports those that are blameless. They have no faults, and they are completely dependent upon those who are around them, their parents, their families, their communities. And so the better a community works, the better it comes together to add value to the lives of the people that live in it, the lower the infant mortality rate is. And so if you're looking for a community to move into, one with a low infant mortality is a good place to go, even if you don't plan on having children, because that is working better as a community. And so the number that gets used is measuring deaths before the first birthday per 1,000 live births. But that's what we're talking about with infant mortality. Now there's good news here. I will say that infant mortality is one of the great success stories of the medical and public health professions. As you can see here on this graph to the right here, let's see if I can get this to work. There we go. Back here, 1 in 7 babies was died before its first birthday. That is back in the mid-1800s. And so we went from there down to low levels like this, really before there was much going on within the medical profession. Before pediatricians could offer better care, obstetricians could offer better care. Just improving hygiene, improving safety, things like that, lowered the infant mortality rate that much. And that's important to know, because if those things deteriorate, if you're in a community where suddenly the bombs are flying or there's a famine or something like that, it can make the infant mortality real bad real fast, regardless of what else is offered. In addition to that, if we look at when vaccines came into place, it's around there, we don't get into special care nurseries and that sort of thing until about here. So the special care nurseries have made a spectacular improvement in outcomes, but you need to put it in the perspective of everything that we're talking about here and understand that really we've gone from about 150 deaths per 1,000 live births down to where it is today in the vicinity of under 10 in the ballpark of 5. Big difference, big success. We also need to acknowledge that there has been a gap in the outcomes in the infant mortality for blacks versus whites. And this graphic goes back to 1915, so it's over 100 years old. The gap is there, and I would say that the improvement has occurred, so there has been a vast improvement in the outcomes for both sides, but we're looking at something which historically has been there for a long time. It is not something that is new. I also want to put this in the context of geography, in the sense that the infant mortality rate in the United States being in the ballpark of roughly 5 or so, we will hear that there's a difference and that we are not as good as other European countries with regard to this, and that is true. But the difference we're talking about is the difference between perhaps 5 and 3. And so that's kind of where the numbers are. If we look around the globe, if we look at sub-Saharan Africa, we're looking at numbers that are in the ballpark of 50 or 100. And so, the move to come to the United States here was a good move. And you can expect a better outcome as a result of those decisions. You can also look at infant mortality across the country. And what I can say here is that infant mortality in Massachusetts is generally among the top 3 in the country with regard to good results. So the results we get here in Massachusetts are really quite good. So what got me involved with infant mortality 25 years ago, I finished doing my work at Dartmouth. I was looking for a project to get involved in. And I'd heard about the infant mortality issue, and this is where it came up. Around 1997 or so, Worcester had the distinction of having the highest infant mortality rate in the state. And the Department of Public Health would hold a press conference. They would release the data regarding births and infant mortality. They, at that time, released the information that the infant mortality rate in Worcester was at its highest. That was about the time that the Department of Public Health got the information from the state regarding what the infant mortality was. And really, that was about as much information as they got. Needless to say, they were very concerned. The city council was concerned. They convened a panel, and they asked them to look into this in more depth. And so the panel was convened, and that's where I got involved. I volunteered to join the group, and in November of 1998, basically went through their information and saw, from my point of view, the issue, which was largely that we didn't have enough information to know what was going on. And so just knowing that you have the highest infant mortality rate is really not enough to act on. And I also knew that the numbers we were talking about, which was roughly 20 infant deaths per year, was a number that we could review, that was something we could approach and address ourselves. And so if we were able to put together a collaboration with the local hospitals, the local health centers, the city clerk's office provided us with death certificates. And so with those relationships and putting together a database, what we did was we started to investigate every one of these deaths when they occurred, rather than waiting for a report from the Department of Public Health, which usually came out 2 or 3 years after the fact. So that's how we got underway. That's how I got involved. And we put together this information. We had institutional review boards. The city clerk's office was incredibly cooperative with us, gave me 10 years worth of death certificates so that I could build up the database. And we also had a resource at that time from the state in which we could query information on their database and try to learn a little bit more. So this got us going. At the same time, there were people on this committee who understood what programs were out there and what opportunities there were. And it was a Healthy Start program funded by the federal government that we applied for. Our sense was that the high-risk group in Worcester was not getting a full dose of all the services they need. They weren't getting as much health care as they needed. They weren't getting as much social services. They weren't getting as much as they needed from that point of view. And so the goal of this Healthy Start program here in Worcester was basically to identify high-risk people, to gather all the necessary information on them, to see how they're doing, and to make sure they get a maximum dose of everything that they needed. And to see if that worked, to see if that was something that we could use to improve their care. So that harmonized nicely with the mission of the Infant Mortality Task Force at that time. That's how it got started. And when we were gathering our information, initially we did not even have a difference between black and white infant mortality in Worcester. And so the first thing we did was to say, well, what is the black infant mortality compared to the white infant mortality in Worcester? And what we found when we ran that number was that the black infant mortality, when compared to the black infant mortality of the rest of the state, when compared to the black infant mortality in Boston, was at least double what it was there. So we immediately honed in on a risk factor that was going on. At that time, Warren Ferguson, who was a family practitioner at the Family Health Center, said, he wasn't sure, but he had the impression that women from Africa were having a harder time, is how he put it. And I noticed it just putting those death certificates into the database, just out of the corner of my eye, I noticed that there's a spot there for country of birth for the mother. And I noticed that word Ghana kept coming up. And so I went back and added the country of birth for the mother to the database and went back 10 years and just filled in the information so I could get a better sense as to what we were dealing with and better understand how Worcester was different from other places. And what I found was that if we looked at African American births in Worcester, those were a low number and going down. If we looked at African mothers who were having babies, especially starting in the mid-1990s, that was a number that was going up to the point where 80% of the black births in Worcester were to mothers who were born elsewhere, usually West Africa, most often Ghana. So that immediately captured our attention. And we further looked at just what the characteristics were of these babies who were dying. And what we found was that a much higher number than elsewhere, a third of the babies weighed under 500 grams. Those are babies that are small, so small they don't have a chance. The best nursery in the world is not going to save them. And so it was important for us to understand that component of this. The other part of it is that a third of our infant deaths in Worcester were to black mothers. And this is at a time when the number of births in Worcester to black mothers was roughly 7 or 8%. So they were way out of proportion to where we would have expected them to be. And most of those, 80 to 90% of those, were to foreign-born mothers, mostly Ghana. So that was the line of discovery that we went through. And what we did in addition, I should also point out that the Massachusetts Department of Public Health was on our committee. And they published a very nice report regarding black births in the entire state that gave us a lot of information that we couldn't have gotten otherwise. And what we learned from that is that if you try to break down the country of origin for the mother, instead of simply saying are they black or not black, but where do they come from and how are their outcomes, we found that looking at the mothers from Ghana, their rate of very low birth weight babies was much higher than African Americans, much higher than other Africans. And so again, we're getting our focus here. We're starting to, we went from high infant mortality to the black population, to the African population, to extreme prematurity and the like. And as I said to you, these 500 gram and under babies were beyond the ability of our system, of our medical science to try to save. The next question, of course, is, well, why don't they just stop the labor? Why don't they treat the mothers during the pregnancy and prevent that baby from being born? And one of the things I need to share with you is that obstetrics is capable of doing a lot of things, but it has not really found any success in stopping premature labor. When a woman goes into the hospital with premature labor, we give them treatments, we do the best that we can. But over the years, what we've seen, particularly with the extremely premature laborers, is that we haven't had a significant effect. Where you saw those other graphs where things dropped down tremendously and had great results, when we look at our ability to stop preterm labor, that's about 30 or 40 years worth of data there, and it's a straight line. It hasn't changed at all. So this is the perspective that I want to give you regarding what's possible, where the problems are coming from, what we need to know more about. So the Infant Mortality Task Force was meeting monthly. They were focusing in on this. In addition to reviewing the cases and generating these reports, we had focus groups within the Ghanaian community. We had structured interviews. We did presentations to the public regarding this, town forums. A group even visited Ghana to try to learn more from the public health people there firsthand. We also went into educating the medical community, giving grand rounds in the hospitals, trying to, again, raise awareness of this issue. And share knowledge, because around the table of this task force were representatives of the health centers, the hospitals, and the like. This was a great way for everybody to know what was going on and what people were doing. And then, of course, there was the case management that came with the Healthy Start program. So, more recently, what have been the challenges? This has continued on. I retired in 2015. Has it gotten easier? Has the data come faster? Has it gotten better in any way? The good news is that the infant mortality for blacks has gone down. There is still a gap, but it is not at the spectacular level of 25 or 30 that we were seeing in the 90s. It is under 10 now. Still a gap, but fortunately at a lower number. Nonetheless, getting the information has gotten harder. That one tool, the online tool, they pulled off the internet. The process of requesting data from the Massachusetts Department of Public Health still takes years. The birth reports now don't contain infant mortality data. they moved that to a different report that doesn't give us information about the mothers at that time. And the timeliness issue is still there. The most recent report is 2021. So if we're trying to do these things, we need to persist in doing this locally. We need to be able to get the information up to date and get the detail that we need. And knowing the pregnancy loss rate, how things are recorded, is getting a little bit more difficult. And actually, this issue of how things are recorded and how we measure problems is something that pops up even more with maternal mortality. So what we know, though, is that the infant mortality in Worcester, the issue was driven by the black infant mortality. The black infant mortality most severely affects African immigrants, especially those from Ghana. And the infant mortality is driven by extremely premature infants, where labor treatments have not been effective and the babies are too small for the current technology. What we need to learn what is there different about this population? How can we study them more? And how can we treat these patients more effectively so that we can get to do a better job? I'm grateful for the fact that the infant mortality rate has dropped, but I can't put my finger on one thing that we've done that has improved it. I can say if we talk about socioeconomic factors and things like that the Ghanaian community in Worcester certainly is a community that is moving up, and that the issues regarding stress and the like may not be as severe as they were in the 90s, but I don't know that as a fact. Now, when we talk about maternal mortality, again, everything you hear just really is a little bit frightening. It's alarming rates, it is double for blacks, things like that are going to really terrify you, particularly if you're from Africa and if you're planning on having a baby. But I, again, want to provide you with some perspective so that you understand what the numbers are and what we're talking about. And the current issues regarding this have to do with the fact that when you measure an outcome, you need to measure it to know if you're getting better or worse. You need to measure it the same way year in, year out. If you want to compare yourself to another country, you have to measure it the same way they measure. And we are in the midst of a period of time where there are multiple measures right now for maternal mortality. And they're reported on at varying times by different agencies. And they all, to the public and even to the medical profession, look kind of the same. They think they're hearing the same thing, but they are not. But we need to know, in addition, that in the United States, a different way of measuring maternal mortality has been introduced over the past 10 years, which is better. It detects more cases. It was designed to be more accurate, but it resulted in a higher maternal mortality rate because it was finding cases that prior to that had been missed. And so the notion that things are getting worse is partially being affected by that. But we need to go beyond that. Knowing what the maternal mortality rate doesn't help us any more than knowing the infant mortality rate doesn't help us. We need to know why. We need to get under there as to what they are dying of and why are they dying, and that's what we need to do. We also need to get more timely reports, and the issues regarding where we get our reports, whether it's the CDC or whether it's the Massachusetts Department of Public Health. Either way, we have significant issues with that. And we also have to make sure that the reports need to target who they're aiming at. If you want to talk to obstetricians, give them a report that focuses on obstetricians. If you want to talk to people in social services or in government, the report needs to address who they are, speak to them in the language they understand, give them points that they can act on. We haven't been getting reports that are that way. Now, again, I want to tell you that maternal mortality, like infant mortality, has been one of the spectacular successes in medicine. If we look back here, going back about 100 years or so, we see that as much as 1 or 2 in 100 women who were giving birth were dying as a complication of pregnancy or during pregnancy. 1 or 2 in 100. So the numbers we're talking about today are much lower than that. Right in here is where women started to deliver in hospitals. Right in here, we're dealing with antibiotics, with transfusions. Those are the sorts of things that made it safer. And then high-risk obstetrics and everything came in here. It flattened out, really. It got to the point where it was essentially flat in the late 1970s and stayed where it was, and only recently has it gone up. So people were expecting it to stay the same. Why is it getting worse? And that's what's capturing the headlines that we're seeing. And so I took this little spot here and put it up here for you to see. When they say that the rate has shot up, that's what we're talking about. We're talking about that blip down there. And so that, again, I hope gives you some perspective regarding what we're talking about. Also, again, when we talk about the gap, this graphic goes back to about 100 years ago, and this is maternal mortality for blacks and maternal mortality for whites, and there is that gap. And it is a gap which, on the one hand, their outcomes have improved with whites. It has improved at about the same rate or more, as you can see down in here. But there is still that gap there. And that is something that we need to understand better. And hopefully I can give you a couple of ideas as to things that you can think about regarding maternal mortality that makes sense to you. So the other piece is that we often talk about how the maternal mortality is worse here. And what I want to draw your attention to is an article from the British literature where they have universal health care and where generally they have better outcomes than we do. And they make 2 points. One is that their maternal death rate is at its highest in 20 years. It's going up there as well, and they're experiencing the same thing. And the other thing is that they are noting that the maternal death rate for women with black ethnic backgrounds is much higher, triple, than what it is for white in England. And so another thing for us to think about, another thing for us to focus on, we need to dig into this a little bit more and understand why. And again, to put it in perspective, these are the maternal deaths in the world. And so we've gone from having nearly 500,000 or so maternal deaths per year in the world, down to a level of about 350,000 or so maternal deaths in the world over the past 25 years or so. That's good, but also to provide you with some perspective, the blue area here is sub-Saharan Africa, and so those numbers are quite high. If you look at the top of this graph here, right there, that red line at the very top, that's the United States and Canada together. And so, although the numbers are higher now than they were 5 years ago, this, I hope, gives you some perspective regarding how we fit into the big equation. When we look at deaths in the United States, roughly 1 million women per year die in the United States. If we look at maternal deaths in the United States, it is in the vicinity of 800 to 1,000 in general. So that is about 1/1,000th of the deaths that are occurring in this country. And I want to just make sure you understand that as well. So getting back to this idea of multiple measures, I will quickly say that the classic measure, the measure that's used around the world, is to die during pregnancy or within 6 weeks afterwards. The other measures are looking at a year afterwards, they're broadening the causes. And so when you hear a number and you're not exactly sure, is this the first number, the 6 weeks postpartum? Is it the one that goes a year? Is it the one that takes on everything that's coming on? Those get mixed up in the reporting that gets done, and it's important to understand that. These come out at different times, they have different sources, and that just adds to the confusion. But to put it into perspective again, the Massachusetts maternal mortality is, as of a report I looked up this afternoon to be sure, is basically in the top 5 in the country. So that differs from what Dr. Castile said, using a different measure, which is a new measure that they started this year, maternal morbidity, the number of women who have suffered a serious illness during pregnancy. The mortality in Massachusetts remains among the best in the country. And the numbers we're talking about are, again, between 10 and 15 deaths per year out of about 65,000 births in the entire state. And this is a state where women in that age group experience about 1,000 deaths per year. So the problem isn't just pregnancy, and it is something where we have to look at the other things that are involving women who are pregnant and their environments. But those are the kinds of numbers we're talking about. numbers that are as low as 8 or 10 in the entire state. So if that goes up to 13 or 14, that's a 40% increase, and that would be how it gets reported. I would also say that when numbers are this small, it is very hard to run just big reports and give you averages and things like that. But you need to know that every maternal death that occurs is thoroughly investigated in the hospital it occurred, by the department it occurred with. Basically, the issue is what went wrong, and it's investigated locally, one case at a time. In addition to that, every maternal death that occurs is sent to the State Department of Public Health and Maternal Morbidity and Mortality Committee, and it is reviewed again there by people who are not connected with the case and who go through all the records that they are given so that they can make a pronouncement regarding the adequacy of the care. So every case is being investigated, and it's important for you to know that, even though they're low numbers. Now, before I said, well, what are they dying of? What is going on? Where can we look for disparities in the life? And what you see here, basically, is that the idea of cardiac conditions comes up a lot. So cardiomyopathy, eclampsia, which is basically a complication of pregnancy involving high blood pressure. And so those sorts of things are coming up a fair amount, and the question then becomes, what's behind that? What is there about this population that could be a little bit different that we could address? And so what the risk factors are that are increasing and affect the Black population more, age is going up with time, and it really affects maternal mortality. Once you get over 35 or 40, then the numbers tend to go up, largely because a lot of medical conditions then become more prevalent, become more common. So women who are 40 are going to have more high blood pressure, they have more diabetes, and they're suffering from those complications. Weight is something which affects the blacks more than it does the whites, and the weight can then have a spillover effect on their risk for diabetes and blood pressure. That is another thing that can have an effect on things. Hypertension. When they looked at maternal deaths that were involving medical conditions and black mothers, 70% of them involved hypertension. And so this is a huge thing to pay attention to. From the point of view of if you're a patient, if you've got hypertension, you know it's something you need to pay attention to. If you don't, you know you don't have a major risk factor in your group. Diabetes is another one where, again, the complications are considerably higher. The prevalence is 50% higher in the black population, and they are more likely to have high blood pressure, they're more likely to have renal problems, and they're also more likely to have bad outcomes for pregnancy. So these are ways of going a little bit beyond race, beyond looking. Some people can look at themselves, they can look at their group and be able to say, these are our risk factors, and these are something that we should be sure that we address and that we try to control. The other issue has to do with drugs, and it always does these days. And in looking at the incidence of drug issues in pregnant women, what we're finding is that it is increasing, and that could be likely a big part of this increase in maternal mortality that we're seeing. And it is increasing more in blacks than it is in whites. So the increasing rate is 6 times higher for the black population than for the whites. That is another one where if you identify it as an issue, it's worth trying to address. And if I look at this graphic here provided by the Massachusetts Department of Public Health, again, what we see is over time, if we looked in maternal mortality reviews, where every one of those cases are being reviewed, what they're finding is that 40% of the deaths during pregnancy and the year afterwards involved drugs or were due to drugs. And so again, there's a risk factor that you can identify that you can try to mitigate in some way, and that is very important. I mentioned to you the fact that we should get reports that are aimed at the audience. And the reports that are released at intervals that are 5 years apart or longer. They aren't necessarily publicly accessible. Most doctors, I would say, don't necessarily know when they can release. And yet, there's a model for something that was used, that was in place, that worked very well from my point of view. And this was aimed directly at physicians. It was the New England Journal of Medicine, which is the largest circulation medical journal in the world. And there was a committee on maternal welfare that for about 30 or 40 years reviewed every maternal death in the state. They had authority to request those records, and they reviewed every death. They got back to the physician regarding the committee's assessment. In addition, if they saw something that was of interest to the public, they published it in an article in the New England Journal, which would be seen by hundreds of thousands of physicians, and it was right there in front of you. I read those when I was in medical school, early in practice, and over time they were releasing several reports a year, which is a good way to get it done. Unfortunately, as is often the case, this was the effort of one physician, John Figgis Jewett, and when he died, this effort went away with him. And so these stopped in the mid-1980s, and what we ended up with was a gap where no one was reviewing the maternal deaths until the mid-90s, and then the Mass Department of Public Health took it on, and they continue to do it to this day. But I also want to just make a plea that the Department of Public Health here in Massachusetts look to New York City as a model for what could be done to try to increase our access to data. The New York City has a open data for all New Yorkers program in which they basically make information available to everyone. And that is a real asset for people who know something, who are interested, and who want to contribute. So going forward, we need to build on the Worcester Department of Public Health Maternal Infant program, the Healthy Babies Initiative, which is what they called the program after I left it. We need to tighten relations with the medical institutions. We need to do things locally. We need to review our own cases, think about them creatively, get to know the community, and try to work these things locally. So there it is. I thank you for your patience and appreciate your time.
Thank you so much, Dr. McGee, for that insightful information. Lots of statistics, lots of helpful information to help to guide us and provide clarity in terms of what we are doing with this foundation, the Motherhood of Africa. I think one of the things that, just based on just the trends is that, as Dr. McGee highlighted, is that there are improvements. The rates are going down, but there's still a gap. So we still have more work to do. And, by, supporting, organizations like the Motherhood of Africa, we are working towards, closing that gap, because that's what we really want to do, is close that gap. And we want to see those numbers go down even further. So just a friendly reminder, on your table, in your booklet, you can scan the QR code to give, or you can go to the back at the table to contribute to this cause. I want to give special recognition. We have the Queen Mother of Ghana, Ohenire III, that is here with us tonight. We also have Nana's mom, Madame Matilda Dapa, that's also here with us tonight. And then we have Tim Murray, the president of the Worcester Regional Chamber of Commerce, that's also with us. So we want to give special recognition to them for joining us. So dinner is being served, so thank you for your patience, and I hope that you'll enjoy dinner. I believe we're supposed to have the documentary. We're going to have the documentary being played during dinner, and after dinner, we're going to have Tim Murray give closing remarks as we wrap up this wonderful evening.
It becomes overshadowed by a level of medical debt. Imagine a scenario where the illusion of welcoming a new life is marred by the fear of financial ruin. This is the stark reality for countless mothers across the globe, particularly in regions where access to quality health care is limited. However, amidst the darkness, there are beacons of hope. Join us as we embark on a journey of resilience and compassion, exploring the profound impact of initiatives aimed at paying the medical bills of mothers detained to the inability to pay after giving birth. This is a story of empowerment, solidarity, and the unwavering determination to ensure that every mother can embrace their new role the weight of financial hardship. Welcome to a narrative of humanity's triumph over adversity, where the creators get to roll as the gift of care. Motherhood Ghana and Obama Services Incorporated, based in the United States of America, have jointly launched a campaign aimed at alleviating the hardships faced by nursing mothers in catering for their medical and later expenses post-childbirth. Recognizing the pervasive nature of this issue across many communities in Ghana and the continent at large, President and the Chief Executive Officer of Motherhood Ghana and Obama Services Incorporated, Ohenere Esi Entry Bosiaku, emphasized the need for intervention to be a game changer. She highlighted that governmental efforts alone may not suffice to provide immediate support to mothers burdened with mounting medical bills after delivery, which in turn contributes to infant mortality and mortality. Ohenere Esi Entribosiaku stressed the necessity for benevolent individuals and the private sector to step in and address the plight of these needy mothers, emphasizing that collective action is required. Speaking after the initiative's launch in Tapa in the western region of Ghana, she explained that the Motherhood of Africa campaign not only covers medical bills but also provides monetary assistance to beneficiaries. This financial support aims to empower mothers to engage in income-generating activities, however small, to ensure they can adequately care for their newborns. As part of the campaign, nursing mothers will also be enrolled for free on the National Health Insurance Scheme, enhancing their access to healthcare services. During the campaign launch, medical bills for 5 nursing mothers were settled, with each recipient additionally receiving 1,000 cedis in financial support. Furthermore, 10 other nursing mothers from hospitals at Apinto Government Hospital, Tapa Municipal Hospital, and Premier Hospital, all in the Tapa municipality, were provided diapers, clothes, and other essential items. Ohenere Esi Entry Bosiaku plans to extend the initiative's reach to other parts of Ghana and eventually across Africa. The Deputy Chief Status of Tapa Municipal Hospital, Gabriel Bichon, expressed optimism that the intervention would alleviate the difficulties faced by health facilities in handling mothers unable to settle the bills. He recounted instances where women in need went into labor without being registered on the health insurance scheme, often leading to adverse outcomes. Commending the initiative, Mr. Beecham affirmed the hospital's commitment to collaborating with the Motherhood of Africa initiative to address such situations effectively in the future. One of the beneficiaries expressed her gratitude and said, throughout her life, women has gradually told service, which is equivalent to $14,400, and prayed for God's grace for the father. She was emotional. And here, some of the beneficiaries also expressed their gratitude to the Motherhood of Africa initiative. Neonatal care is a type of care for babies born premature or sick, and the unit provides care for babies soon after they are born, that is, for the first 28 days of life. Neonatal babies are sometimes delivered having problems with the heart, stomach, or oxygen issues, and need care at delivery. The assistant in charge of the medical office of the municipal, Ellen Thomas, who was full of praise for Motherhood of Africa Foundation and Obama Healthcare, revealed that they have been compelled to pair preterm babies into several communities due to the lack of incubators and phototherapy at the facility. She enumerated some of the challenges.
We have a unique community In fact, the last time your mom and mama of the wife of no, they minister and they can see zero. They say, I'm sure the teacher and man and the teenagers, mothers from the moon, no nature of the girls. Yeah, people put this in some fantastic business. But still, I young one with the soft life, money things. The young degree, I still unit. In fact, they were trained, they were challenging degree because they refer us to almost way back now, close to and I'm free. We have ourselves of the other for they are for Asante, they are for Christian and Catholic, and they are by the Sayman and the Catholic and service at safety. I can't find time you're just asking you from the bar to the cabin. And you can talk about saying that before now, a bar, and you can't say a air column, and how they say, radiant woman, a baby back, they say, oh, baby, go, yes, no, who's going to come? Why come? I'm going to have a big there for. Put lights, no more again, they don't listen to the school, and support. They were talking about four. In ways like the idea, one is the baby, one baby, private to the back, incubator, sometimes two. The fact lines, we put the different warnings on one here. Maybe they don't know what I mean. Especially with our great mothers, it feels to go with the challenge. When it's all money, the bed of the most serious the 9 months. I see another day, but extremely 5.5, 6. So then, nothing 5 and following so oxygen get brain. So we have already come up with our family, our family. I want to do the empire and my phone was around also has one family. Also, after the children so we begin to know concerning most of our mothers who are in supported them with their own we appreciate them with us, and we want to use this opportunity to seek for their help concerning our older children in Papa Hospital. So we have a very big challenge concerning most of the equipment that we use to help them solve their health needs. And one of these problems are sleep. Most of the time, they come here with severe respiratory distress that we need to support them to breathe until they can breathe on their own. And we have only 2 CPAP and we have a that is intensive care, major intensive care unit. That is where we have this center. But most of them come here since before they develop this respiratory distress, they do giving immunization where they can't place at the major intensive care unit before the children start. So they need to come to many pediatric clinics, and it can be very difficult. You have to do inclusive exercise for them, and it's not healthy. So we are needing if we can get a CPAP for the pediatric clinics. And the other hand is our beds. We have a bed capacity of 83, and we almost admit about more than 35 cases on the road. When it happens, we have to send some of our cases to sanitary units for them to be taken care of, which is not happening at home. So we are indulging on them if they can help us get new beds. Some of the old beds are rusting, even some of the little and by the time 2-3 years, they will get rejuvenated. And also, we used to have cardiac monitor, which we used to monitor our babies when they are in distress, and then we have their intensive care. But it goes down, so right now we don't have cardiac monitor when we used to monitor our patients. And majority, we had a lot of that we used to improvise in monitoring these cases. And as I'm talking to you, we have a lot of the press of data, which is not helpful at all. Our flow meters, which we used to do them often, that's our oxygen supply device. We have only 2 flow meters. So imagine we have 3 to 4 babies or children in distress that we need to deliver oxygen. We have to go all around the hospital searching for kilometers to help these babies or these children, which is not helping us. We also have a problem with our baby pots. In fact, we don't have pots. Most of our pots have broken down, and we are left about 2 pots that we raise our babies. This is not helpful. This place is a referral center, so most of our peripherals refer their cases here, especially the neonatal jaundice cases in Worcester. We have only, with the help of Worcester as an organization, and the main ones, they helped us with 2 fireflies, and it is supporting, but as we can say, it's not enough. Since the place of the referral center, we get referrals in African even our private facilities, we get referrals from there. It's not happening. Right now, we have 3
Are you folks just getting here?
Yes.
So you need dinners. Did you order? Oh, there's only chicken left. Is that okay? I'll get you place settings. I just cleared them, but I'll be right back. Right? Here's one.
also want to acknowledge Father Enoch. Father Enoch and I have the privilege to serve on the Anna Maria College board together. And we have also with us from Anna Maria College the Senior Vice President of Academic Affairs, Dr. Chioma Uruchakwa, who's here. And I'll just make a little plug for Anna Maria. You know, it is a school that is very proactive in areas of healthcare. For a small little school that maybe doesn't get as much attention as others, they're also very active in outreach to West Africa in particular, and the number of students who are first generation and international students is a point of pride for the school. So I just want to acknowledge both of them for their service to Anna Maria College, and it's great to work with both of them. Well, we're doing some applause. How about a round of applause for our servers and the people in the back who cooked that great meal? Yeah. Well, I want to thank Nana for the invitation just to give the closing remarks, and I want to try to be brief. But, you know, when you've been around as long as I have, it's hard to sometimes be brief when you get to see the work of different people in this room over a period of time. I was privileged to get elected the mayor of Worcester in 2001, and I was a city councilor for 2 terms before that. And I can remember when the city public health commissioner, working with individuals in the medical community, were identifying this scary phenomenon of maternal mortality and infant mortality, and how it was disproportionately affecting our African immigrant communities. And then shortly thereafter we saw an increase as well in our Latino populations. And for a city with all of these educational institutes and these great and well-respected healthcare providers, it was a deep cause of concern. And so then City Manager O'Brien, myself, again with input with leadership from the health department, convened the Infant Mortality Task Force. And serendipitously, a doctor named Dr. Dale McGee got involved. And while he is not a researcher, you couldn't tell that by his presentation, but he dug into this and took this personal, literally going through the records of the babies and the moms to try to see if there were common threads and issues. And he brought an attention to this that previously there was not, and a focus on this which previously there was not. And as you saw from the trend lines, you know, this progress has been made, but there's more work to do. Because as Worcester became more diverse, as we saw the percentage of people coming from West Africa and immigrant populations who may not have had access to care in the way we maybe are accustomed to here, we saw that this was continuing to be an issue and a challenge. And so I want to thank Dr. McGee for his work over decades on this issue. But we also live in an increasingly mobile society. And so we can stay very focused on the issue here in Worcester and in central Massachusetts. But if people are coming and going, which is the new norm, from countries in Africa here, and coming maybe from places again that don't have that access, we continue to have the challenge. And so what Nana is doing is so unique. It's so unique. Because what the Motherhood of Africa Foundation is seeking to do is to bridge that gap and create that sharing of information and healthcare best practices and healthcare training and healthcare equipment, so that we can address the issues, the underlying issues on both continents. And that is really important. You know, just this past fall, our chamber hosted, working with the Honorable Consul General Kanisafo Agiai, Mike Kane from our office, and many of you were present. We put together over a half-day event focused on Massachusetts, and particularly Worcester and Central Mass and Africa and Ghana, and how do we create more economic ties, healthcare ties and educational ties. And if we're successful in that mission, issues like this, we empower people to bring that information, that education, that equipment, that access on both sides of the Atlantic. And so I just want to thank Nana for her commitment. She runs a successful home health care agency which provides first-class care, and I can tell you that from some patients that I know. And she's been very focused on growing and expanding that business, and we appreciate, again, her involvement in the chamber and getting the word out. But nonetheless, she takes time away from that business, sometimes time demands from the family, to try to build that bridge. To build that bridge about access, information, and healthcare that leads to better, healthier communities, both in the city of Worcester and Central Mass, but in Accra or in villages in West Africa. And that is really, really important. And it's important to both of the futures of this region and places in West Africa in particular as well. So I just want to say thank you and congratulations for the work that you've done in putting this together. You know, for those who may not know, healthcare is the single biggest employer in central Massachusetts. And so we have vast knowledge and experience that we can share. And we want to be known as a place of innovation and of education and of healthcare quality that is so important. And Nana, your vision to connect to be that bridge is something we can all take inspiration for in supporting the Motherhood of Africa Foundation event. And I also want to acknowledge Dr. Maddie Castile and the work that she has done to build upon with Dr. McGee and others. I know Gemma Kamara and the work that she has done in establishing the Massachusetts Organization of African Descendants is all about building and strengthening that partnership. So thank you for your work.
Thank you so much, Tim. What a way to end tonight, and you know, a nice bowl that Tim has crowned this evening with just that wrap up. And we appreciate, you know, every speaker, everyone that came out tonight. We want to definitely recognize our sponsors: Fidelity Bank, Loyal Home Services, Omama Home Healthcare, Moad, Marty's Kitchen, Erua Event Planning, and Century 21 Realty. All our special guests, we just want to say a big thank you for coming out and showing up as we're leaving. A few reminders that on July 1st, the Office for Motherhood of Africa will be at 370 Main Street, Suite 720. If you have any more information, you can visit the back. You know, they have their phone numbers, website, everything, and you can get more information. Remember, do not leave tonight without giving something. You can visit the back to give something, or you can scan the QR code, donate via Cash App or PayPal, and we will truly appreciate it. You see the work that we're doing in Ghana, and we want to continue doing that. And so with your support, we're able to do that. So thank you so much again for coming out to the Motherhood of Africa launch. I hope you have a safe journey home, and spread the word and let persons know that, you know, Motherhood of Africa, we are live and we're about to close that gap that Dr. McGee spoke about. Thank you so much.